The learning objectives will be to kind of update you on what has been reported about TAVI in the last, I chose 2 years because that was the last time we had the meeting. And I do have some cases to highlight these new developments. So this is the first thing about TAVI. TAVI is now more common than any other form of surgical aortic valve replacement. And you can see here, this red line is all AVR. So this is AVR CABG, AVR mitral, AVR tricuspid, just AVR. And you can see here in about 2019, TAVI surpassed that. And this just got published last year in the Annals of Thoracic Surgery through the TVT database. And I can tell you that my experience is with TAVI that every patient wants TAVI and they want it through the right radial artery. I cannot tell you how many times when I'm talking to a patient about TAVI, they go, and you can go in through this, my wrist right here? And never say never. Maybe next year I'll be showing you the new transradial TAVI valve. But I want you to understand that as good as TAVI is, it's still not perfect for everyone. So this is a case that I did last week before I came down here. An 87-year-old woman, class 3 heart failure. She has severe aortic valve stenosis. She has coronary disease, severe 3-vessel disease here. This is kind of an LAO-ish caudal image here, and you can see like right here in the proximal LAD, there's a 70% stenosis, and there's also a 60% stenosis here, and there's a stenosis here in the circumflex, and also in the right coronary artery. She also has bad cerebrovascular disease. She has an occluded right carotid artery, and has 70% stenosis in the left carotid artery, and she has terrible peripheral vascular disease, says that she's not a transfemoral candidate. So this is kind of like the ideal patient that when I see, I'm thinking, this would be a great patient for TAVI. 87 years old, if we could get her in or out of the hospital in a day or so, she would do well. But regardless, she was not a candidate for TAVI. And I talked to her and her family, and she was symptomatic enough that she was willing to undergo surgery. So we did an AVR 3-vessel CABG on her, and she's coming along. She's not going to be out of the hospital in 2 or 3 days, but she's going to get through this, and she's going to be okay. Now you have to remember that TAVI valves, they're expensive. So this is data from 2017 that I just got off the internet. And if you look down here at the Edwards Sapien S3 valve, $32,350 per valve. And from what my understanding is when I talk to our finance people, that number has not changed. Now we get a little bit of a discount if we do 100 valves, or if we do 200 valves or 300 Sapien valves, but there's no across the board reduction in price. And Medtronic, Edwards was the first to market. So, they really have made a ton of money off of TAVI. And then you have the Evolute Pro Plus valve, roughly $30,000, comes in just a little bit under, but they're the second to market. And their share of the market is not as much as the Sapien valve. Now compare this with like an Edwards surgical aortic valve. This is like the Magna Ease valve, $5,700. Medtronic has their version of a biological valve, $5,200. But the cheapest valve that I could find was the Onyx valve, which is a mechanical valve, $4,500. So, if there was one best heart valve, there would be one heart valve on the market. But if you can get like 10 different mechanical valves, 10 different biological valves. So last year, we had a new TAVI valve get approved by the FDA called the PORTICO valve. So this is probably the 4th valve on the market. And this is a self-expanding intra-annular valve. And around the same time last year, Boston Scientific took their valve, the LOTUS valve, which is a mechanically expandable valve. They took it off the market because the delivery device for it was very difficult to use. You had to rotate the II to the left and to the right, and it just, it was not a keep it simple type of delivery device. So now we're down to basically 3 valves on the market, but they're not all the same. So there's the Sapien S3 Edwards Life Sciences, which is a balloon expandable valve. There's the Evolute Pro Plus, which is a Medtronic superannular self-expanding valve. And we also now have the Portico valve, which is, as I said, this intravalvular self-expanding valves. So we have 3 valves on the market, and my understanding is that when you have 3 companies, then you start to jockey for price and things like that. But it's important to note that it's not like a soft drink type of competition where you have Coke versus Diet Coke versus Pepsi, because these valves are all kind of different. And so it's more like a Coke versus coffee versus milk type thing, you know, where you might have a Coke with your hamburger, but you're probably gonna have milk with cookies. And, you know, what are you gonna have coffee with? Maybe after dinner, you know? So there's different indications for each one of these. And so there's no real kind of direct competition with them. And that's a problem because, you know, the price is just not going to come down until there's 2 balloon expandable valves on the market or 2 superannular self-expanding valves on the market. And I just don't see that happening because it costs Edwards about $1 billion to get their valve on the market. And companies like, you know, the Boston Scientific with the LOTUS valve, you spend all that money and then you get an FDA recall. So my take on valve types is that our group favors the SAPIEN S3 valve. That's the Edwards valve. And we use it because it's easy to use. You put it in, you position it where you want it, you blow up the balloon, you take the balloon out, and you close the femoral artery and you're done. And we've done these valves probably in 45 minutes, an hour. And this is our go-to valve, and we probably use it 95% of the patients. We also use the Evolut Pro Plus valve, but we use this for specific instances, like a really calcified left ventricular outflow tract where we're worried about annular rupture with a balloon expandable valve, or maybe a real small valve because the hemodynamics may be a little bit better in the Evolut Pro valve than in the 20 millimeter S3 valve. But we only use it in about 5% of the patients, to the point where you kind of have to refresh your brain when you're doing a Evolut Pro valve about how do I put this valve in? You know, I need to review that. And we put in maybe 5 of the LOTUS valves, but they were really difficult to put in, and then they got taken off the market, so we haven't used that, and we don't use the PORTICO valve. But like I said, I think consumers would benefit. And by consumers, I mean patients and doctors and hospitals and the government. You know, they would all benefit, you know, if we had several other valves on the market, but I just don't see that happening. Next, I want to talk about bicuspid aortic valve. This is a great case. So this is a 63-year-old man. This proves once again it's never good to be a great case, you know. 63-year-old guy, bicuspid aortic valve stenosis. You can see the valve here, you know, heavily calcified bicuspid. This is probably what we call a Sievers type 1. So this is the conjoined commissure here. This is the left, right, non. So this is a right non-conjoined commissure. And you actually look at this calcification here, it almost looks like the tip of a spear. And you can imagine, you know, if you put a valve in here, you're gonna push that out that way, and hopefully you don't push it through the heart. But he had pancreas cancer, and he needed to have a Whipple. And he needed to have chemotherapy and radiation. And so, you know, the multidisciplinary consultation, you know, included the oncologist. And so they had this whole thing mapped out where he would get like 6-9 months of, you know, multiple doses of radiation and chemotherapy. And then there would be like a 6-week window where we could sneak in and do his aortic valve. And then after 6 weeks after he finished the chemo radiation, he would get his pancreatectomy. Well, you know, that's kind of hard to, you know, do a surgical aortic valve replacement on somebody, you know, when their white blood cell count is dropping and their platelet count is dropping, and then you're going to do a surgical aortic valve and they're going to recover enough in, you know, 4 or 5 weeks to get a Whipple. So we did a bicuspid aortic, a TAVI on this patient, and when we did a balloon valvuloplasty, and the guy just about died when we did the balloon valvuloplasty. He developed acute aortic regurgitation. I mean, we had probably 30 seconds before we were going to just lose this guy. Unfortunately, we got the valve in, and we deployed it, and boom, he turned around, and he got through the TAVI procedure well. No pacemaker, got his Whipple like 6 weeks later, and then a year later, he developed a metastatic liver lesion. And I don't know what the presentation was on Monday or Tuesday about oncology, and if you have pancreas cancer, you're more likely to die of your pancreas cancer than your, you know, coronary disease or whatever, and we'll have to see what happens with him. But we were able to make that work. So the problem with the bicuspid valves is they're different than the tricuspid valves, and this is just one example of that, where you have this like tapered anatomy configuration. So the annulus, in this instance, let's say it's 529 millimeters squared, so that's for a 26 millimeter SAPIEN S3 valve. But 4 millimeters above the annulus, the minimal diameter is 22 millimeters, so you would want to use a 23 millimeter SAPIEN valve. So the danger is if you size in the annulus here, you're going to get rupture of the aorta here. So when you have a bicuspid valve, you need to pay very close attention to the anatomy on the CT scan. And this is kind of the take-home message for TAVI and bicuspid valves. There's a low but higher risk of stroke with TAVI valves, such that some centers go to using a cerebral protection device on every patient that they do a bicuspid valve on. There is a higher risk of pacemaker implantation than with surgery. There's a low but higher risk of annulus rupture, and annulus rupture is a problem. You are not going to be on the rapid pathway to get out of the hospital if you get an annulus rupture. And there's also a higher risk of mild or more paravalvular regurgitation. So, my job as a surgeon is to just tell the patient all these things and then help them make a decision. So my take on TAVI for bicuspid valves, it is FDA approved, but it's not CMS approved. And that's a problem, because if you want to stop something, you can do all the legislature you want. Probably not going to do it. But if you don't pay for it, it's not going to happen. And that's what CMS is saying here. We're not going to pay for it. And a TAVI hospitalization is probably like $100,000, $150,000. Now, we've probably done 30 or 40 bicuspids, and we've never had a problem with Medicare turning them down. But I have seen patients who had severe MR, who were low risk, who decided they want a MitraClip, and Medicare refused to pay for it. And they had to mortgage their house to pay the bill. So, this is a potential, and I just tell the patients about this, but most of the time they want to go ahead with the procedure, but it's probably not ready for prime time. What about failing surgical aortic valve? So this is a case of a 75-year-old man with severe AS. He had endocarditis twice in the past. He had an AVR cabbage in 2010 with the mitral flow valve. That valve wore out, so we did a valve-in-valve on him in 2016, and we put in a 26mm sapien S3, and it didn't really help him. His mean gradient was like 35 after that procedure. And I never would have thought that. A 27mm mitral flow, that's a pretty big valve. But we didn't really help him that much. And he kind of limped along for several years, and now he's got patient prosthesis mismatch or prosthetic valve stenosis, but he's also got this pseudoaneurysm in his mitral valve right here from his previous endocarditis. So this is kind of a long axis image. Here's the aortic valve here. Here's the mitral valve. You can see that. And keeping with my previous discussion about colors, you can see there's lots of bad color here. So this guy has two bad valves. So what do? So we operated on him. We took out his all of his aortic valves and repaired his pseudoaneurysm, and he just went home yesterday. So let's talk about isolated redo aortic valve replacement versus valve-in-valve transcatheter valve replacement. This is a study out of Emory. It's not a very big study, 86 patients in the repeat S surgical aortic valve group and 187 in the valve-in-valve. But I want you to take it away from this graph here is the indications for operation. Look at the redo SAVR group, endocarditis, perivalvular leak, leaflet thrombosis. I mean, those are high-risk cases for redo aortic valve replacement. You're not going to see any of those in the valve-in-valve group. The valve-in-valve group are going to be people that, probably have mostly isolated aortic valve, prosthetic aortic valve problem. And here's the outcomes here. Death. One patient died in the redo surgery group, 3 in the TAVI group, so probably a wash there. Bleeding, surprisingly, was the same. Usually, TAVI usually trumps bleeding. Stroke was higher. This is a really high incidence of stroke. I don't know what to say about that. And in follow-up, this is an important slide. The mean aortic valve gradient here, you can see in the redo SAVR group, it's lower than it is in the valve-in-valve group. And that's been demonstrated several times previously that, you have that Russian doll thing where you put a valve inside of a valve. You're not going to get full expansion of the TAVI valve, and the hemodynamics aren't going to be that good. So my take on failing surgical aortic valves is there's no zero-risk option. There's no operation that's going to be no pain and no morbidity. And I always assess for patient prosthesis mismatch on these patients, and the best way to do that is to go back to the week after their original surgical aortic valve and look at that echo and see what their transvalvular gradient is and what their effective orificial area index is. If they had patient prosthesis mismatch then, it's not going to be any better if you do a valve-in-valve. And I don't ignore additional cardiac morbidities. If they have coronary disease, atrial fibrillation, mitral valve regurgitation, tricuspid valve regurgitation, we can fix all those with surgery. And the other thing is we can put in a mechanical valve. And probably 30% of the patients in our experience who undergo redo surgical aortic valve choose for a mechanical valve after they first had a biological valve. And I just don't focus on the aortic valve. So let's talk about this technique to treat patient prosthesis mismatch in the valve and valve group. This is called balloon valve fracture. So you have the TAVI, or the surgical aortic valve here, say it's a 23, and you put this 25 millimeter balloon in here, or 29 millimeter balloon, and this is a special balloon that you can do high pressure dilation with, and it basically just fractures the sewing ring here, and then we can put in a bigger TAVI. And that's kind of, when you do this, it's like one of those visceral things where when it pops, you can feel it, you can hear it, you can see it, and it kind of, you get a wave of nausea, you know, when that happens, because, you know, there could be problems. So this study here, 81 patients, I just want to draw your attention to ventricular septal defect happened in 2 of the patients, although they go through great pains in the study to say that it didn't really matter, and the patients did well, and also central aortic valve regurgitation. You know, that can be a problem because that's valve and valve. So now you have Russian doll and Russian doll and Russian doll. And that's probably not going to be a good thing. So my take on balloon valvuloplasty is I look at that echo right after surgery, and if their effective orifice area index is greater than 0.85, I think we'll probably be okay. We probably won't even need to do a balloon valve fracture. If it's between 6.5 and 0.85, well, those are the patients I talked to about it might be better if we did surgery. If they insist on valve and valve, then we'd be ready to do a balloon valve fracture. And if it's less than 0.65, I'm really reluctant to offer any therapy for that unless they were just prohibitive surgical risk and they had like bad aortic regurgitation. When in doubt, I think surgery. Cusp overlap technique is a new technique that we have. Normally, the way we do this is we get this 3 cusp view here. So we have the non, the right, and the left, and we put that's our orthogonal line. And the cusp overlap, we put the right and left over each other so that we have the non here. This is where the conduction system is going to lie, and we position the valve right underneath that little dot right there. And you can see that with the cusp overlap technique, the valve depth is less than it is with the standard technique. And importantly, the pacemaker rate is much less than with the standard technique. And anything that can lower pacemaker rate, I'm all on board with that, as long as it doesn't increase the paravalvular leak rate or the valve migration rate. And in this study, that didn't happen. The problem is that sometimes it can be a steep RAO angle and the II can be right there, so you can't get to it. So transcarotid access is a new technique. It may have lower risk of stroke than the transaxillary. The problem is this. The radiation for the surgeon is really high, 175% higher for the first operator. So basically, I think you're just killing the surgeon. And this is maybe a conspiracy theory, but you know, I don't know, we'll have to see what happens. So there's no new practice changing or price reducing TAVI widgets out there. There's new applications, and they have been developed and they continue to be developed. Pacemaker remains a problem. And there's no new data about valve durability, and that's probably the most important thing we're waiting for. Finally, I would say be kind to your surgeon and don't irradiate them.